And there was.
All right, so health and welfare is back and it's February 27th. And again, still February 27th. And we're going to just have a short discussion regarding the committee bill. I just want to share with everyone kind of the pathway here. And for me, it's been exciting because starting work on this bill back in May and then seeing the Oliver Wyman report come out and the reaction of the hospitals to that, and then working to ensure that Act 167 work transformation goes forward in a way that doesn't upset our care delivery focus. And then trying to put together some of the Oliver Wyman recommendations, which does include that one recommendation is on electronic health records. The Green Mountain Care Board is very enthusiastic about planning, and I wanted to know what we need in our state, so added that in. And then the whole concept of pricing and cost was an issue that everyone I talked with during the summer and the fall, it was cost. The problem is all the problems that exist. And so it's my goal has been to provide solutions and to build solutions. And what's kind of neat is that we're all working together now. We see hospitals coming in, Green Mountain Care Board, AHS, community services coming in and interested in helping coalesce around solutions. And we're hearing solutions. And the notion of having some immediate price reduction, cost reduction, particularly in hospitals, and our largest hospital, is part of what we're doing here. So having Craig Jones come in, I've talked with him about some of my ideas for solutions, and we shared concepts. And now we can build legislation, I think, from where we are. And so I asked Jen, and Senator Gulick and I sat down with Jen the other day and went through our framework, looked at the testimony that we've had and tried to modify that framework into legislative language. And then more recently, last night, I spent time going through what Jen calls a drafty draft. And she and I are going to sit down again today, go through the drafty draft and see what we can get on our table for tomorrow and have something to consider. So that when we come back after the town meeting, we'll be able to get testimony from folks who are interested and turn the drafty draft into committee bill and present it, get it up on the floor. So that's where we are. It's been a long journey, I think, and we've all been thinking about this, and the others have ideas that they'll want to put into the bill going forward, and that's how legislation is done. So we'll keep working on it. So Jen, I thought might be helpful just to go through what we have for the framework so people understand what's there. We could probably put that up on, now that you put your computer away, we could put that up for folks to see. It's on our web page. And we're just going to spend like 10-15 minutes on it. And then we'll come back with an undrafted draft.
Unless.
Yeah, the windows will be closed.
The sills won't be fogged.
Right. Frost will be.
I can see the clock if I look in the hands.
Oh, well, it's about not quite quarter after. We'll spend,
I'm just gonna go look in Senate Finance to see if it's on my desk in there. I'll be right back. I just normally I have it on me. That's okay. Sorry about that. Okay.
So
I
I'm
think
in the
just-
office of legislative counsel, just say that so I can start talking. No, go ahead.
Just go through it.
Okay. So this is the same draft outline that we have looked at before. I haven't made any changes in that document. I'll just mark mine up a little bit. So the first part is addressing a statewide healthcare delivery plan. It directs the Green Mountain Care Board and Agency of Human Services in collaboration with others to develop an integrated statewide healthcare delivery plan that builds on data from the Health Resource Allocation Plan, Act 167 Transformation Planning, and related data to ensure access to high quality, cost effective acute care, chronic care, primary care, hospital-based, independent, and community-based services across Vermont.
So, and I just, we heard today, there's needs to be co-leadership with those two. We need to have some direct.
Right, which I think is, I mean, it.
Yeah, my concern in all this, I guess, is that we have a crisis situation going on. And I want to make sure we don't dump so much on them to do that we distract from their ability to deal with the crisis. So it sounded like getting that leadership council in place was primary, and then getting the cost of at least one hospital under control, which would.
So Mike, you're absolutely right. And so one of the reasons that you're seeing the organization of this as it is that getting the cost control in place. When I started putting this together and writing it up, that's frightening. It would have been like putting the Oliver Wyman report out again. So the planning piece seems less concerning. But at the end of our framework, we have that what I consider to be the emergency steps that need to be taken, sort of the immediate step of maybe 5 hospitals and have a 3-year plan to ratchet down those costs within the budget process and within reference-based pricing. So you're right, Senator. Don't want the longer term planning to get in the way of the short term.
And that might maybe.
You want to change the order?
Yeah, maybe that should be at the front. First, we want you to deal with the crisis and make sure we've got a health insurer that can cover claims. Make sure that our hospitals are in line with national standards in pricing. Because 80%,
Or at least with Maine, right?
well, yeah. But if 80% of the teaching hospitals nationwide, which was Greg Jones' testimony, can break even on Medicare, why can't we?
Yeah.
And so that,
That
would
so the
solve-
question you're asking of Jen is, how difficult is it to flip the order?
Not difficult.
Okay,
you just
let's do it.
Yeah, awesome.
Yeah, let's
So
do
wait,
it.
can you tell me what you just
cut
decided?
paste.
Yeah, pretty much.
We want
They
to put budgeting and cost containment first.
Budgeting and cost.
Deal with today's crisis.
Okay,
Get the cost of our one real outlier under control,
okay.
which should then, and then you can deal with the smaller.
Yeah, and the detail, we can, we'll
In the
put the
plan.
details in
Yeah.
for those things, but
I tend to agree with Senator Cummings, plea for a little bit of strain and methodical practice. Because I think it's a good plan overall. And so here's my opinions on it. We're taking a lot of testimony. And it's a lot all at once. And I just want to make sure that when we're taking a big bite, if you bite it more than you can chew, or sorry, if you bite up a lot, you don't want to choke on it, you want
Right.
to chew it first.
You got it.
So it just has to make sure that it,
167 was.
Right.
yeah,
And
and
you
it
know,
needs to be
you're right.
methodical.
And you're right, but, they're not, they're not dependent on one another. The planning piece is different group. The board is the financing, but they'll be involved in the plan. And there's a time frame that we need to have in there for the plan piece for sure. As there is a time frame for the emergency response, right? So, yeah.
Yeah.
Okay, good. So we're gonna do that. Senator Cummings has moved to move the emergency response to the front of the bill. Cool. I like that.
Unanimous consent.
There we go. And then we'll work on details for that, of course, but then what do you want second? And why don't we do the high level
Yeah.
for the next few minutes on what we have here?
And I think
I'm not sure. It's on here or somewhere.
I think we had talked about doing away with the idea of kind of separate hospital strategic plans in addition to
Yeah,
this overall plan. So some of this will.
Yeah,
because they're already doing planning, but it's statute, so why do something?
Right, there's various planning there. There's the transformation work that they're doing.
Yeah,
That may create its own sort of strategic plan.
and I know the hospitals were not a big fan of that, especially the reviewing and approval of those plans. And then I know Green Mountain Care Board wasn't even a fan of that either.
no, we're not a fan of it.
It takes a lot of
Page
effort.
one, sort of in the second big bullet, just talking about not
Oh,
doing
yeah.
hospital
I
strategic
already crossed that off. Yep,
plans.
thanks.
Yeah, Senator Bullock and I had talked about that when we met with Jen.
And I'm not sure where you landed on requiring AHS to monitor other state agencies for alignment. The board seemed to have questions about that. I think
Yeah.
about that.
I don't think we had that in there.
So I don't think I put it in the draft.
It
but
doesn't
wasn't
make
sure what that-
sense, honestly.
Just-
Their Act 167 work, for example. The one thing Brendan Krause indicated is how hard they're working on transportation. Well, they can't do that alone, so I'm not, let it happen organically sometimes, right?
If we want to tell them, I've got good people.
Yeah.
They know where we need to go.
Right.
That, to me, you give them the tools to get there, but don't. You gotta trust them at some.
We're not mechanics,
No,
right?
well, I am.
Part
In
two.
over my head.
Part two,
Part two is this health system evaluation, but part of what it does is direct the Green Mountain Care Board and AHS to jointly establish an advisory committee. So this may be where you want, if you want to do an idea around kind of a joint leadership council, like Chris
Yeah.
Jones was talking about. Maybe we sort of modify that concept, this concept in that direction.
what do we think about that?
I remember AHS, they said they want more clarity on what that's gonna entail. They want like a lot more
Yeah.
information. And another thing is the,
Let's start with the joint leadership, moving it from advisory to a joint leadership
leadership.
Yeah.
Okay.
that Craig was talking about.
So instead of this, just changing the name from advisory committee to joint leadership.
Yeah, and I think we may need to give some thought to
How you
sort
do
of
that.
fleshing out what it is that they are
Leading.
leading and doing. I think the idea of this advisory committee was to have stakeholder participation and seat at the table in providing some guidance on directions. That may still be something you want to do, but you may want to have a more kind of static leadership council and then have an advisory committee advising them.
Yes.
Yeah, and well, I know Craig was just sorry. I know Craig was just saying that, like we don't necessarily need more regulation, that the Green Mountain Care Board already does the regulatory work, and then the AHS does the governance part. So I don't have any issue with changing the name of it. I just want to make sure that it's fleshed out in such a way that you're not going to have more regulatory bureaucracy, like you said.
Yeah,
More
exactly.
bureaucracy.
We got too many.
Yeah. Well, and Foss is already on 10 lines.
Yeah, I mean, what they said is Green Mountain Care Board has hospitals. They regulate them. But we've got this other whole movement to primary care and the medical records, which AHS seems to be responsible for, and all those other things like telemedicine and transportation, and they all need to be coordinated, because we heard this morning about primary care and the medical records and getting primary care to understand exactly who they're responsible for and have the payers know who they're paying for. That's a lot of work, but it's not something that the Green Mountain Care Board necessarily does.
No,
They were set up to regulate hospital and health insurance prices, which are primarily based on
Right.
hospital prices.
yeah, and once those are under control, then.
Right.
So can I say something?
Yeah.
Yeah, thank you. I know I was running down the hall, so I missed I don't know if you completely finished with part one. But speaking of AHS and Green Mountain Care Board, it seems like the two of them having a shared
Well, we said that,
leadership.
co-leadership, we did.
No, I'm saying, I think it would be easier if one had the leadership role.
Okay, we can talk about, it.
Okay.
yeah.
Okay.
No, actually, the suggestion that came to us from Elliot Fisher was that they have co-leadership. And I think, yeah, it's hard, but it's imperative that they work together, and I think Craig also said that. And I know that one side, I know,
We can go back to the Czarvina concept. I've always wanted to be the healthcare Czarvina.
I know,
I mean, I think. I think you can structure leadership as different ways, and you can have, two people leading, which. In my experience, doesn't work great, or you can have one leading with, consulting the other and getting advice, in an advisory position.
but we can,
But, okay.
so that'll be, there's a flag on that one.
Why don't we ask them?
We will, that's the point, yeah, we will.
See
But
what they. think
not
they
today,
can
because
do.
we're gonna get something on the table for them to be active.
Right.
We'll just spend a couple more minutes, because I want to give time just to take a breather for Jen, and then we'll go on to 63.
All right, part three, and yes, these parts can certainly be put in whatever order you want. But it's that idea of integration of clinical and cost data. We had talked about, and I think there had been general agreement on having agency services not vital leading this. So that's one of the changes that I have made, but looking at interoperability and ease of access for patients, providers, and payers.
Okay, the only one that said no to VCures was Blue Cross Blue Shield, and they said they didn't think it was relevant. I think I've been convinced it's relevant. What I don't want to do at this point in their lives is to put extra cost onto them, and that includes if all you gotta do is a computer transfer and you push a button, but if it's going to require that they do a lot of extra work.
This isn't
I'm
the
doing a
time for
cost
that to
benefit,
happen.
yeah, this may
Right.
not be the
Understood.
time
Yeah,
to do that.
I think
Yeah,
the
the
way
timing
I've
for this.
structured it at the moment is sort of building on what AHS has been doing in the Medicaid space and how they can expand that
right.
to
Okay,
include
that
more
would-
payers.
Okay.
And more data sources.
As long as it's not by next Tuesday, you have to have everything done.
Make it retroactively effective.
Yes.
All right,
The first time.
the next part has several subparts, and it's on hospital budgets and payment reform. It sounds like this is part of what we may be moving to the
To the
top of
forefront.
the bill.
Yeah.
So the first one is around reference-based pricing. And in putting this language in, I put in a concept that I think you heard from somebody, but of potentially allowing the board to take Medicare, if they start with Medicare benchmarking, but to maintain a kind of parallel structure in the event that Medicare rates are facing different federal pressures than our rates in this state. So that we're not, inextricably linked to Medicare prices that may be experiencing volatility.
Right.
Exactly.
Exactly.
That doesn't reflect the realities here.
We don't want to go down too far, right?
So you'll
Keep it profitable and sustainable.
right. I think it's helpful to begin with so that everybody's working from the same list of prices. But it may make sense in the future for the board to maintain its own set.
Adjusted,
Yeah.
yeah.
And FYI, we are having someone come in and talk with us. Couldn't get her this week because she's at a conference, but she'll be coming in and talk about pricing and net patient revenue, total cost of care, and then different types of pricing payments, which is maybe a step or three ahead of where we are with the bill, but it's not a step or three ahead of where the board is and what the board can do with some of our larger hospitals. So it's important for us to understand their stuff there.
Probably us and the Green Mountain Care Board, it sounds like maybe some of the hospital boards could use some edification.
They may, yeah.
And exactly what, well, we had Springfield, because it's an FQHC, had to have, the majority of its board had to be community members. Which doesn't necessarily mean that you have the background or training to make the kind of decisions that, these are major businesses that you're running. And
Well, you're getting to with what Craig was talking about in terms of the governance
yeah,
being so critical,
Yeah.
regardless of what it is.
yeah. And I have a feeling all hospital boards are not created equal. So,
And I keep forgetting this, but we are going to take a field trip to the hospital. Me too.
What are you doing to us?
Taking a field trip.
Julie, what do you think sounds now?
Okay.
The
All right.
Commission on Education went to Newport our last trip.
So let's wrap up where we are, and then we have a lot to talk about, and this is going to be fun. Maybe.
So we have total cost of care language in here about establishing total cost of care spending targets. And looking at rates that would bring spending in Vermont more in line with national growth rates and national spending, although also added in language recognizing our demographics and the rural nature of the state. Yeah.
Dr. Fisher, when the second public there, said it's, you could remove that with all the hospitals are doing that on their own. They're incentivized to do that on their own naturally.
We'll think about that. There might be things that we can do to incentivize that.
Then we have global hospital budgets directing the Green Mountain Care Board to establish global hospital budgets that are consistent with the total cost of care targets. And start with global hospital budgets in 2027, which I took to be hospital fiscal year 2028, which starts in 2027. Beginning with the 5 largest Vermont hospitals. I did that a little differently in the draft, but we can change it. I just said non-critical access hospital.
Right.
And then mostly
Right, and then
the other 5. And build on reference-based pricing. Then there's Green Mountain Care Board regulatory duties. And some of the pieces in there, including ensuring that decreases in hospital services result in, and I think the testimony you heard was maybe not just decreased insurance premiums, but perhaps investing some in services you want, like supporting population health and primary care.
we got that.
Did everybody get this?
And then the requiring hospitals to use a uniform system of accounts. I think you had done away with the idea of a single independent auditor. I think you've heard testimony that
Yeah.
There's enough auditing happening, that's not a problem.
Yes.
Wait, payments. So that was. I haven't changed anything, it's still the same draft.
So we should cross that off though, right?
Yeah.
Yes, I just haven't-
You won't see it in the draft. The
Gotcha.
drafty draft.
I know,
or the-
it's for my own,
Or the
it's that last bullet.
weatherized
That
draft.
last
More
full bullet,
payments.
yeah.
Okay.
And just a procedural question,
Yeah.
Jen. Where are we gonna see these changes reflected, in the next step? Are you gonna, make another version of the overview with those
I
changes?
was not
Or are you
planning on, it. I think we're gonna
the
start
draft
focusing
bill?
on the language, yeah.
Draft bill.
Yeah.
Okay.
This was just to get us to the draft bill.
We'll sit down with our highlighters.
How many pages?
It's only 19.
Awesome.
So I didn't do much with this payment for clinical services because it wasn't clear to me how that really fit with everything else you were doing in the bill. So if there's something more you want to do in this area, we can. But I think you're already talking about payment models. I put in a lot of alignment with the statewide healthcare delivery plan. And wasn't entirely clear what these improvement plans were.
Open the door some way.
Yeah.
Yeah.
And then resources, creating positions, I think, we probably need to put intent language for the future years. Because nothing will be, future years can't be funded yet, so creating positions with no funding may create, some tension going forward, but I'll leave that up to all of you, and I don't know how much we need to appropriate.
I started thinking about how much and thinking about there might be some needs for contracting and stuff, so we'll probably have to
Yes,
talk about
yes,
that.
for
But
positions.
they're gonna need help. You can't do this without our resources.
Yeah. Greg Jones brought that up today too.
Who did? Greg, yeah.
Yeah.
Good.
All right, cool. Ready for me to vacate the seat? And
Not quite, yeah, I just one final thought.
I just.
One final word.
Yes.
When we're contemplating the leadership piece, I do think I would love to circle back around with Dr. Fisher and Dr. Jones, because
Yeah,
what I heard them say is they need to work together. I'm not sure I heard them say they need to lead together, so I just want clarity on that.
well, you've got to have you have to have a defined leadership. That's what I think Elliot was saying that, I think Craig was also.
Okay.
Well, we'll circle around that one a little bit.
Yeah, and touching on the leadership or advisory, whatever it's gonna be called at the end of the day.
No, I'm talking about here. It's a little different. But go ahead.
Well, yeah, I'm talking about under part two, the joint advisor. Oh, that's not what you're talking about. I'm sorry.
It's okay.
Okay, I just wanted to bring up that whatever the composition of that counselor for the committee is gonna be, I want to make sure that the hospitals are gonna be represented. That was something that we got testimony on from. Oh, Devin.
I just to let you know, that's one of my comments on the drafty draft, so
Okay.
when we get the weatherized draft, maybe you see it there.
Okay.
This is great. Cool. All right.
When we run this,
Thank you, Pam.
I would like to just make sure that Green Mountain Care Board gets a chance to look at this. I want to make sure we aren't giving them more than they can handle.
No, and I think what we've heard is if they can do it, if they have the resources,
Okay.
that's key. So when we get the bill, we will invite folks and initially some key players to testify.
Because you know better than we do the likelihood of their
Yeah.
getting the resources.
We got it.
Okay.
And expertise. So, one of the thoughts is they're starting to do all the reference-based pricing work. They may need expertise on the board. They may contract out initially for the first year, and then as they build positions and people that they can fill in with that. So there's some ideas. Am I losing you?
No, not at all.
Okay,
Conversation.
nonverbal conversation. Always good. That's how I grew up communicating across the dinner table with my brother. Okay, so we are going to shift gears to S63, and did you want to start us out? Diane, why don't you come on up? I was gonna call you representative, but I said no.
No, only senators get to keep their titles for life. Representatives cannot.
Really? No kidding, I didn't know
I
that.
did, yeah, that's why I always call Senator Air, Senator Air.
Aren't you so
Well, I was
honorable?
always told, it's how many there are. Anyway, there's only one mayor, so I should be called mayor.
Okay. There you go.
Yeah, as long as you're on.
Anyway, interesting fact. So,
Think
thank you.
anyone's going to do it.
Thank you. So for the record, Diane Lankford, Green Mountain Care Board at the moment. So I'm just going to help to facilitate this quick conversation. Thank you to the committee for taking up S63. It's a very important bill to the Green Mountain Care Board. And we appreciate this time. We know that you have a hard stop at 11. And in working with you and many of the experts at the Green Mountain Care Board to keep this contained, we're going to move through this quickly, if you don't mind. So sections 1, 2, and 4, you will have testimony written and it's in your inbox that's very supportive and comments on it. So I don't believe that there's a really need at this moment to bring that to a lengthy conversation just for today. So section 3 has to do with the ACO changing the percentage, which is also in the big bill of the budget at the moment. And I think you've seen that in a variety, maybe not, but it's being taken up mostly in there. And in this bill, it's also there for redundancy and to have it as a part of the big package. Section 5 is the ACO, which is where you should probably hear from the expert witness, which is sitting behind me, that Michelle Sawyer is going to speak on section 5. And I believe you have online our ledge counsel, or not ledge counsel, sorry, our legal team, Mike and Mark. They can speak to the rest of the bill, but many others are probably on Zoom in case you've got a question. So we're gonna keep it to 3 people that you hear from, but everybody's here for you. And then I'm gonna
Thank you.
You're welcome.
This is
We're gonna
great.
turn it over to Michelle right now. We'll have her take a seat.
Good.
Thank you.
Welcome.
Hello, thank you.
Very quickly, introductions.
Ann Cummings.
Martine Jenny Lyons
Yeah.
and Larry Hart had to leave with an emergency.
Okay. For the record, I'm Michelle Sawyer with Green Mountain Care Board. I'm here to address the proposal in section 5, which has to do with how the Green Mountain Care Board regulates accountable care organizations or ACOs in the state of Vermont. So the current statute, as you well know, came about with the all-payer model of the agreement with the federal government. And so within the current statute, there is a lot of language in there that is specific to that model to ensure that the way that the Green Mountain Care Board was regulating ACOs aligned with the agreement that we had with the federal government and aligned with those goals of that model. So a lot of the language that you see removed in this section is because it was specific to the all-payer model and is no longer, at the end of 25, will no longer be
Irrelevant.
relevant. Exactly. So the goal overarching for this section was to make it agnostic to whatever model we're in next, whether it's ahead, whether it's something else. The idea is that there's no model-specific language in how the board would regulate ACOs. So brief touch on how the Green Mountain Care Board regulates ACOs is through 2 mechanisms. The first is through certification of ACOs and through an annual budget review. And I think what I would like to do is
You have is your testimony going to be up on our webpage?
I can certainly provide.
Okay,
some-
that'd be good, because then that'll save, I'll be paying much more attention.
Sure.
This is great.
Okay, perfect. I wanted to touch on current state versus what's in the proposal for certification and the same with the budget. So you can get a good concept of what's changing and why. So as far as certification is concerned, the current state with certification is that all ACOs operating in Vermont that contract with Vermont Medicaid or a commercial payer must go through a certification process with the Green Mountain Care Board. The only ACO in Vermont that has done this is Home Care Vermont. They received their certification. It's a one-time process back in 2017 for their 2018 year. And every year there is an annual eligibility verification process, which is a much lighter lift for everyone. And the board does have the authority to decertify an ACO at any time. That's OneCare Vermont. There is a second kind of ACO in Vermont that is becoming more and more prevalent. These are Medicare only ACOs. And in the current statute, these ACOs are not required to be certified in any way. In the future, in this proposal, what we are recommending is that all ACOs, regardless of who the payers are that they contract with, go through a certification process. Doesn't matter if they are a Medicare only, doesn't matter if it's more like a OneCare situation, they would have to go through a certification process. And the board would have the authority to decertify any ACO if they're no longer meeting the requirements for certification. As far as the budget review process goes, the current state is that all ACOs, regardless of payer, so OneCare plus all the Medicare only ACOs must submit an annual budget for the Green Mountain Care Board to review. The authority that the board has is to either approve those budgets or approve with modifications. There is no way to deny a budget, if you will. And so in the future, in this proposal, what we were recommending is that a budget review only be for ACOs that are contracting with Medicaid or commercial payers, ACOs that are really handling Vermont dollars. So we could dig into the financials of those ACOs and how those dollars are being allocated and eliminating that process for the Medicare only ACOs. And there's a few different reasons why we think that's the right move. And why certification is a better move for the Medicare only ACOs. These Medicare only ACOs, they are generally multi-state. They operate in many different states and they are not centrally located in Vermont. And they contract directly with the federal government regarding how their funds flow, their model of care, that sort of thing. So the authority that the board has to modify their financials or their model of care is really limited under a budget review. It's just not quite the right regulatory mechanism. And there's no way, should there be a bad player that comes in, for the board to say, we don't want you here in Vermont. You are not benefiting the providers, you're not benefiting Vermonters. But this correction or this proposal would correct that through moving them into a certification process.
Right, the assumption has always been we're gonna have our own little ACOs, but.
Right. I don't think it was probably ever dreamed up that we would see these entities coming into the state at the rate they're coming in. So adjusting the regulations so that the board has a little bit more authority over these players can be a good thing. So that's generally what's in this proposal. And so I touched on some of the whys. We can't stop any bad players. We haven't really come across that yet, but there are about 500 of these ACOs all over the country. They are often private equity backed, so they're in it to make money.
I was thinking that one.
Yes, I'm not saying that all of them don't have parts in a good place, but they have motives. So just to be able to have a little bit more control of who is in our state borders would be nice.
Do we have already? Say the basic.
Sure, we have 3 currently. We have Lore Health ACO, which contracts for the FQHC in Springfield. We have Vitalize Health. Vitalize is an organization that has dozens of ACOs. So one ACO here, I believe they are in Bristol and in, gosh, I can't remember the other town, I apologize. And then the third one is Aledade, which is up at the Notch in Richford.
What's the name of it?
Aledade,
Okay.
yeah. So we have 3 so far. It's been increasing year over year. And we fully expect that the number of these ACOs will increase in the state. And that is because OneCare is closing their doors. So as providers are losing out on these extra payments that you've heard testimony about, They're losing out on the MIPS reporting exclusions. These other ACOs offer those sorts of things. And so it really does behoove providers looking for an one care alternative to explore these ACOs. And these ACOs want to expand their network as well. So I predict that the number and the prevalence of these ACOs will continue to increase.
There's money to be made.
Let me ask you a question, with the loss of One Care, they certainly had, from my perspective, mechanism or an ability to do quality metric analysis. What is happening to all of that, call it infrastructure? And how can we take advantage of that, maybe in our bill that we're writing right now?
That's a great question. And I have asked One Care. I can only speak on behalf of
Sure,
One
I
Care.
understand.
And so this is secondhand.
Yeah,
It's my understanding that they are in communications with AHS about what the current state is. And so that conversation is happening outside of the Green Mountain Care Board.
yeah.
As the regulator, we don't really play a role in that.
No,
particular
but it
aspect.
will be important going forward from a regulatory perspective to understand the quality outcomes from some of the work that's going on. So having that work done somewhere and continuing with what's there, increasing the risk pool involved, I understand is important. So we might mention it somewhere in our bill. We try to do it, but because I know that they're doing a lot of good work.
Yeah,
They just haven't had enough people
yeah.
in the pool. Yeah.
And I will say that these ACOs often come with pretty advanced data analytics,
Yeah.
report and technology. They come into these practices and the way that they make money is one way is to improve the quality scores. So the MSSP program, which is a one type of Medicare only ACO, they certainly have their own quality reporting that's publicly available through the CMS website. So you can dig into that. And we are requiring these ACOs to report their Vermont specific outcomes to us on an annual basis. Yeah.
So they're incentivized for quality care.
Yes, well, they're incentivized to reduce there's two pieces to it, to reduce the cost of care, total cost of care, while maintaining certain quality. So there's a shared savings, shared loss thing. If they are to spend less than that total cost of care target, then there's savings, but there's also a quality aspect to that calculation. So they are also incentivized to maintain or improve quality.
So they don't.
Yeah, right. They don't want to just cut services and thereby, reduce the total cost of care, but.
Okay,
Yeah.
and just so I'm following here, so you're not saying necessarily that ACOs are bad, there could be bad
No.
actors, but overall you envision there's gonna be a lot more coming into the state, and you wanna make sure that they're certified.
Precisely, that the board the board has the ability, if needed, to remove some. I think also the certification process just makes a whole lot more sense than a financial review of these entities over which we really don't have any control over their finances. But should there be another ACO like One Care in the future that contracts with Medicaid or a commercial payer, we would do a full, budget review for those specific ACOs.
Okay, so that's section 5.
That's section 5. If I may, just the fees
Yeah.
involved with this.
Please, yeah.
You've taken some, or I guess you will have testimony in your email about the changes in the bill back. So removing the ACOs from that total percentage of bill back and going to more a fee-based schedule, much like the CON process. So it would be $10,000 for an initial certification. That's a one-time certification for an ACO. And then annually thereafter, the eligibility verification is $2,000. And then for an annual budget review, which is a much larger regulatory lift, it's $125,000. That's what it's being proposed.
Cool. So there's a fee in here. This means finance. We'll take a look at it.
I'm gonna have a bill on my phone.
We're gonna get you some work. That's good.
Thank you.
Thank you.
All right.
So, Madam Chair, the next speaker is online on Zoom, and it is our legal department. I think Mike is speaking, but Mark is also with us for backup. And there he is.
Okay, terrific. Thank you for being here. So
Thank
go
you for-
ahead and talk for the record, and I would like to hear what you have to say.
Sure. Thank you. For the record, my name is Michael Barber. I'm the board's general counsel, and I was going to run through the remaining sections of the bill, spending probably the most time on section 7, which I know you might have some questions about. So starting at the top of page 21, section 6 of the bill would amend a hospital budget statute, 18 VSA 9454, to allow the Brattleboro Retreat to maintain a calendar fiscal year. This corrects what we think was an unintended consequence of the legislation that first brought the retreat under the board's budget review jurisdiction. We understand the retreat supports this change as well, and without it, the retreat would need to change its fiscal year to be the same as the state's acute care hospitals, which is October 1st through September 30th. Moving on to section 7, this would amend another hospital budget statute, 18 VSA 9456, and it would do so in a couple different ways. So first, if you go to the top of page 22, these changes to subsection D1 here would align the statute with the board's current practice regarding the timing of the retreat's budget review. Again, the retreat has a calendar fiscal year, and so its budget gets reviewed a little bit later than the 14 acute care hospitals in the state. The other changes in section 7 primarily deal with hospital budget enforcement orders. So a little bit of background, every year the board issues orders that establish budgets for hospitals. Hospitals are required by law to comply with their budgets. And if a hospital deviates materially from its budget, the board can order the hospital to take certain actions to correct the deviation. And we refer to this as budget enforcement. Section 7 would change the venue for appeals of hospital budget enforcement orders from the Superior Court to the Supreme Court. Currently, if a hospital wants to appeal an order establishing its budget, that appeal goes directly to the Supreme Court. But if a hospital wants to appeal a budget enforcement order, that appeal goes to the Superior Court. We think it's appropriate for both kinds of appeal to go directly to the Supreme Court, which is the venue for other appeals of board orders. Section 7 would also specify that the contested case requirements of the Administrative Procedures Act, or the APA, do not apply to proceedings to establish or enforce a hospital budget. We strongly support this language. At a high level, this will allow the board to continue effectively and efficiently enforcing its budget orders while still providing hospitals with due process and a meaningful opportunity to be heard. Just as background, the APA requires agencies to use trial-like procedures for certain proceedings known as contested cases. So, for example, in contested cases, the rules of evidence generally apply and parties have a right to cross-examine witnesses. The legislature can and has exempted proceedings from these requirements. So, for example, the legislature has exempted certificate of need reviews from the APA requirements in order to give the board more flexibility to develop a record in those kinds of matters. The board's proceedings to establish a hospital budget are not contested cases. However, there is a question about whether hospital budget enforcement proceedings are contested cases. Last year, the board reviewed 4 hospitals for potential budget enforcement. Ultimately, the board ordered 2 of these hospitals to reduce their prices to correct for excessive revenue growth or growth that exceeded their their budget allowance. Both hospitals have appealed those enforcement orders, arguing that the board was required to follow these contested case procedures and failed to do so. And obviously the courts are going to decide those appeals and tell us what the law currently requires. And we're not asking the legislature to weigh in on that dispute in any way, but regardless of the outcome of those appeals, we don't think it's in the best interest of the state to require the board to use these trial type procedures to deal with budget deviations. Moving on to section 8, this amends 18 VSA 9572, which is a statute that pretty tightly regulates the meetings of NACO's governing body. And this change here would limit the applicability of that statute, which is really passed with OneCare in mind, kind of an ACO that was at the center of our healthcare reform effort in the state. It would limit the applicability to ACOs that contract with Vermont Medicaid. And then finally, section 9 of the bill repeals 18 VSA 9573, which is a statute that requires the board to prepare an advisory opinion regarding any population-based payment arrangement between DVA and an ACO. We refer to this as the Medicaid advisory rate case. This kind of review was something that was deemed important for the all-payer ACO model. And with that model going away and OneCare ceasing operations, we don't think that this is relevant anymore. And I'll stop there. I'm happy to answer any questions you have.
No, thank you. It will be extremely helpful to have your testimony in writing so we can post it on our webpage and then go back through and understand exactly what's happening, in particular with the appeals process. Thank you. Senator, this question.
All right, I just want to make sure I understood. So you do agree with the repeal in the section 9? Correct?
Section 9? Yes.
Yeah. Okay, thank you.
So just FYI for folks, this is a bill that the board asked to have introduced. And so it's important for us to look at it.
Yeah.
Any other questions for Michael while we have him? No, this is good. We may have questions going forward from the board generally, and especially you two who are here, Michelle and Michael. Thank you. So we'll leave it there for now, and then we'll come back to that. Hoping that we have some time pre-crossover to see what we can do.
Thank you, Madam Chair. I just think we're left with 1 minute to spare.
Thank you.
Done.
Did it. And I know that there's interest out there and in the room on testifying on this bill, so we'll make sure we get that. Good.
We have a part to play in separate.
One other note.
Oh, no.
So we're gonna shift gears yet again, because we're good at doing this. Oh, right in front of me. We're going to move on to S36. And yesterday we heard from Chad Bigger about what's happening in his area in Rutland, and then also his thinking about some other things that are happening, and that the agency is very interested in working on, and apparently there's some budgetary stuff going on. So we thank you for coming in, and offering some comments. Do we have something for you on our webpage or not? Testimony, yeah, we do.
Yeah.
So we should look at that and we see it's going up there. So our goal, I guess, just to frame this, there are a lot of people interested in recovery. Obviously, substance use disorder is a significant issue in the state as it is in every other state. So putting some continuum care in place and having language that supports that is important to us here. And I know the work that you're doing outside and building capacity, infrastructure in parts of the state that need it. It's not the time, it's the place where people stay, not the length of time, but it's the length of where they stay. So we appreciate your helping us with this. And if we can get some language, I know Chad is going to be offering suggestions, and if we can have suggestions that go together, that we can make either through this bill directly or through this bill to appropriations somehow, that would be useful. Here you are. Thanks for being here.
Thank you for having us. For the record, I'm Jenny Samuelson. I'm the Secretary for the Agency of Human Services. I'm glad to be here with you again today. I'm also bringing my colleague Monica Ogilvy, who is the Medicaid Director in Vermont here, and also a member of my executive team at the agency with real purview over a broad set of not just our Medicaid, but our health programs. We have a couple of other colleagues in the room who I may do a phone a friend from the Department for Mental Health, from the Department for Corrections, and from the Department of Health, who've really been integral into what I'm going to lay out. In speaking with the chair and at your wish, our goal today is to walk through what we are presenting this year as augmentations to the continuum of care, first for our co-occurring system of care, but particularly focused on substance use disorder. You will see many of these items included in the budget and also in the public safety omnibus bill that has both a health focus and a public safety focus. So I appreciate the opportunity for us to be able to now walk through this with you here, given your purview over the broader health and human services system.
No, we really appreciate the work that you're doing outside, and this is good.
So just to give a little bit of background, as many of you know, we've been here with many of you for many years. We have been a leader in Vermont in substance use treatment, and particularly in opioid use disorder treatment. But I think it's important for us to acknowledge that the environment has significantly changed with the emergence of stimulants, and particularly with polypharmacy. We are beginning to see many more individuals and many more communities impacted, not just by opiates, but by a much broader set of substances coming into our system. These are further exacerbating, and I want to make sure that we do mention this, the issue of drug trafficking in our community, and the nature of that has changed. It's changed in the time that I've been working in the Agency of Human Services, and we also have an overlay of the housing instability that we have seen. And so that's why the agency is working really to look comprehensively at this across all of our departments. For the past year, we've been meeting with people with lived experience, with families, and with communities, and with treatment providers, and the judicial system and law enforcement. We've gone around to many communities in Vermont and taken the opportunity during Capitol for a day to identify what their pressures are. And so the plan this year really reflects the gaps that we heard in our system, many of which we've been working on for years, but also some new components. Our goal really is to help support people so that we can have healthy people, which helps get us to healthy communities. I think that's what you'll see overall. I do want to acknowledge that while many people who have substance use, they don't impact our communities. In fact, they're more likely to be victims in our communities. Having gone around the state, there are a small subset of individuals, and you'll see that reflected in the plan, whose behaviors are having an outsized impact on communities that I am concerned are shifting the conversation and the stigma back. And so that's why you see us as we work collaboratively with the Department for Public Safety and the Agency of Human Services, really echoing out, this is a plan to help build healthy communities across our state. Also, as background, Hub and Spoke, folks may not know this, that emerged more than 10 years ago. It really was implementation focused on targeting opioids. And with the shift and change in the drug supply that I mentioned before, our current treatment tools that we have need to evolve, because the medication-assisted treatment, which is the foundation of Hub and Spoke, doesn't work with stimulants. The work that we've done with Narcan, it doesn't necessarily work with stimulants. So we need new tools in this space. We also heard some gaps that I think are important for us to reflect. And you probably heard this from Chad and from Don Tatro and others that we've been working with. Those gaps really are stagnant lengths of stay. I think that that's what your bill S36 really looks at, is with this increase in individuals and complexity, we want to make sure that individuals can stay in the care that they need for as long as they need it. In addition to that, there's access barriers. When people are ready for treatment, what we've seen is folks are not sure where they should actually go for that treatment. And some of the treatment providers that we have, based on the emergence of federal regulations, only provide a portion, for example, of residential treatment. And we really want to get to a comprehensive approach. There's limited options for people who are in crisis with the public inebriate beds folding in many communities. Folks aren't sure. And that was really a system that had a three-pronged approach. It had public inebriate beds for those folks who were inebriated and just needed to sleep off. We have the hospitals for those folks who are in medical crisis. And for individuals who are a risk to themselves and to others, we use our correctional system in order for folks to go and have a safe space where they can have someone the next morning ask, just like our public inebriate beds, ask them what treatment options that they might help make those connections. But unfortunately, if they can't be safe in our public inebriate beds and in our hospitals, this has been a key tool that's been really important to us. We're also seeing housing instability affecting recovery access, and we're seeing treatment gaps in our correctional system. Our correctional system has done an amazing job at being a leader on the front, similar to our Hub and Spoke, of providing medication for treatment for opioid use disorder, but it's not at a residential level of care. And we know that 70% of the individuals who are incarcerated are getting treatment. So I think it's important to ground us in what we've done for the last 3 years. We really have been working on moving to a co-occurring system of care that looks at implementation of 988. Most folks think that's just mental health, but 988 is for individuals in crisis and substance use or mental health crisis. The same thing goes for the deployment of our mobile crisis beds and our mental health urgent cares, and in integrating clinicians into law enforcement. So that's really helped to stabilize with a focus on making sure that individuals get the right care. And we know that emergency departments are not always the best place for folks in mental health or substance use crisis. So these initiatives have really been targeted at that. We've also tried to ensure that we're doing co-occurring care. Many of the individuals who have substance use disorder benefit from making sure that we integrate mental health treatment in that, and vice versa. And so you see us really targeting designated agencies, our hubs, and our primary care practices, which have been at the front lines of the treatment that we are providing. So as we think about this coming year, we really thought about what the gaps were, and we are going to, in some of these areas, take a multi-year approach. For example, we know we need a significant number of beds in recovery housing, but the units don't exist for us to do that. Same thing with transitional housing for corrections. And so you'll see us in some of the areas taking a multi-year approach. For crisis, for the crisis stabilization, this is really focused on 2 pieces. Our public inebriate beds were challenged to be successful because of staffing in those beds And because individuals, they became sober and the next morning folks work to connect them with services, but sometimes it takes more than 24 hours to connect someone with services. So what we are proposing is rebuilding and merging. Think about co-occurring as a key theme. Rebuilding and merging the stability beds, the mental health stabilization beds with the public inebriate beds as a way to make sure that the staffing model, because keeping staffing for public inebriate beds 24/7 when they may not see someone for a week, and for mental health crisis when it uses the same skills wasn't making sense. So we're going to merge those, and that does two things. It addresses some of our staffing issues. It also assists us with ensuring individuals are getting co-occurring support and care. There's a sunset. Remember, I said for stabilization, that's 3 prongs. We want, for some of a small subset of individuals, the ability to be safe in our PIP beds and in our hospitals without injuring themselves or someone else is not possible. And so we have been using the transportation to corrections. Folks are not charged, but they go to corrections, they spend the night there, and then we move on. That ability to do that is sunsetting. And so we're asking for a repeal of that sunset. For residential treatment, and I will pause after we go through residential treatment to see if there's any questions or comments. When we think about residential treatment, when we're hearing the barrier that we're hearing about getting in and being able to stay long enough, we really looked at how we can address those pieces. For residential treatment providers, we're asking them to do the full continuum of care. So it doesn't matter if you are medically withdrawing or withdrawing. You can come in. It doesn't matter if you are relapsing and coming back. You can get in. In addition to that, we want to make sure we see multiple transitions as a major gap in our system. And having gone and looked at other models like Granite's State over in New Hampshire, reducing that number of transitions is really important. So by putting the continuum all in one space, there's significant value in that for all of our treatment providers. We've seen some extend into the lower acuity care, but we want all of them to extend in that. We also know that a key point that individuals struggle with is making that transition from residential care to the communities. So ensuring that we have navigators, and you'll hear this in the theme with DOC residential care too. We have navigators that can help support people in making that transition. In doing that and adding additional opportunities in our residential system of care, we know we need to look at our payment model. Our payment model, as you've heard over the last couple of days, may have some incentives in it or may not that make it so that individuals are not getting the care for as long as they need. In addition, did not contemplate this full continuum. And so we are committing to evaluating the payment model and making sure that payment model both incents what we're looking for and gives the flexibility for someone to get the care that they need for as long as they need it. And I think that that's important, putting arbitrary dates on the amount of time that someone needs care, particularly because, some individuals are coming in with opioid use disorder, some alcohol use disorder, and others with polypharmacy. Putting arbitrary dates rather than looking at what the need of an individual is doesn't make sense. So we're going to try to match the continuum with a payment model that helps to incent it. In addition to that, we're going to provide residential treatment level of care. And everyone asks, is it voluntary? Yes, all of the treatment and corrections is voluntary. We're proposing converting one of our correctional facilities into residential treatment. What we know is that individuals are getting great care. They're getting medication assisted treatment. They have access to counseling, but it is not the level of intensity that you would see in residential care for those who have higher level of acuity and need that level of care. And so with our correction system, as folks are getting initial stabilization, which is what I would say is happening in corrections now, getting stabilization, they aren't leaving with the tools that they need to be successful. And so our goal here is to ensure that we have a continuum that goes from those who are judicially involved to individuals who can be successful in communities. And if you can be successful in the community or judicially involved, we're going to pair that continuum in residential treatment with try to pair it with pretrial supervision if for some reason you're struggling to be successful with the courts. So again, I don't want to mix things too much, but with the residential treatment in the community, it's a full continuum. And we're going to provide that in our correctional facilities too, so that we have the options for everyone. I'm going to pause there because it's a lot of content already, and then we're going to go to a couple of other augmentations we're going to make.
And just, so you know, the testimony that we're getting at 11:30, we can go over a little bit in time. So, because we want to make sure we hear everything. Thank you, Senator Gulick, and then Senator Cole.
Thank you. Thank you, Madam Chair. I have a bunch of thoughts and questions. The first is, I remember we had a joint hearing about a year and a half ago with corrections. It was very interesting, and I remember talking about the inebriate, they call it
Public inebriate program.
yes, and how those were diminishing, or we were losing them.
So
Yeah.
in our communities, that's exactly what's happening.
Yeah,
We are seeing fewer and fewer public inebriate programs because they can't staff. And so, because they can't staff them, again, because it's intermittent, like you know, it's unclear in Burlington on a Thursday night or a Wednesday night whether someone will need that service. And so by merging that with the mental health stabilization beds, it allows us to bring more of them back online.
Okay.
Dual purpose.
yeah, because it seems like that is sort of a low cost, low intensity, maybe not low intensity, but just a good option for care. And it seems like caring for folks in corrections seems like it's probably pretty expensive and maybe cost prohibitive, and that there's also stress with staffing.
So 70% of individuals who are currently incarcerated are getting medication assisted therapy. This isn't asking new people to come into corrections. This is providing enhanced treatment for those who are already in corrections. We're not saying we want more people to go to corrections. What we are saying,
Good thing.
yeah, I know. What we are saying is those who are in corrections deserve the opportunity to get the same standard of care in corrections that they would get in the community. And you hear that echoed about what we're doing with our broader healthcare. And right now, individuals who are in corrections, we're one of the first in the country to do medication assisted therapy, but it's important for us to acknowledge we're not doing residential care, which is the community standard of care.
But you're contemplating it, sounds like sort of a new facility.
Where we are contemplating recognizing that and taking what St. Johnsbury is likely the facility, taking St. Johnsbury and providing residential level of care for those who are incarcerated. So again, it's adding care for people who are already in our care and custody, not saying we want more.
Right. Yeah, no, thank you. That's really helpful. And our last question is, and I don't remember the name, but what was the out-of-state healthcare provider that we were using?
WellPath. Well, now it's WellPath.
We're still using WellPath, and will
Yes.
they be the ones providing the treatment and the care?
So that's one of the things for the first portion of next year, we are going to have someone come in and say, help us figure out this is the right way to do it. This is the right way to provide treatment. I don't want to commit to who's going to provide that treatment until we've finished that analysis and determine, can WellPath do it? Or is it better for us to bring in a subcontractor or a contractor to do that? So that's more to come. We'll spend the first part of next year making sure that we do it right rather than guessing at it and just doing it fast. And then probably the last quarter of next year, our goal is to get the program up and running.
Okay, thank you.
Yeah.
Senator Douglas.
Thank you. Madam Secretary, thank you for joining us. So I have a question about mental health stabilization beds, if you can explain exactly what those are. So for disclosure, I work under your department and I work in a crisis. I'm sure you're all very deal with background. So I wanted to see if that's kind of what you're talking about for one. And the staffing issue that you mentioned is really real. At my facility, we are very understaffed, and the structure of our agency has been in flux. We don't have a manager for the facility anymore. So, the staffing issues is really probably not only just staffing, but also quality staffing. Or, even if somebody's unqualified, would they have the ability to become qualified? like, you know, entering into it, I didn't really have qualifications, but I worked there long enough that I've been able to get it. So staffing is really a big problem, and I've loved everything you said so far. The issue is really is the staffing.
Yeah, exactly. What we're recognizing across all of human services is that the crisis that we face is both, it's not just financial, which everyone talks about, but it's staffing as well. And so we recognize that we've been trying to split too many people in too many different places. So by merging, you're exactly right, the crisis stabilization beds, and we're going to pilot this and there are a few organizations, the designated agencies parties, they want to do this. We'll start it with a few of them, see how it works, and then our goal is to expand that over the next. Remember, I said some of these are several years long projects. Expand that over the next couple of years, and so it's taking that and merging the two so we can be more efficient with the staff.
With the resources we have, spread things out. Okay, yeah, that sounds good. My other question for Hans and the batons is
Yeah, go ahead, ask your
Yeah.
question, then Senator Cummings.
is you mentioned instead of length of stays as it is specified in the bill, to when people need it or when they're ready to go, how the determination be made, because I do know that sometimes in the work that I do, people don't want to leave, even if they're ready to leave.
Correct.
And also like you're trying to set people up and make, again, homelessness, substance abuse, mental health, all swirl, big old
together.
plate of spaghetti.
Corrections
And
do.
corrections do, of course. And so sometimes people want to leave, and then when you're trying to get them set up with other services, and you put the responsibility on them to, you know, here's a list of phone numbers you should call. You know, you should need to set up your housing, you need to set up getting yourself a credit card, set up all these things. And if they don't want to leave, they'll put off those things. They should put them off.
What I'm hearing you say is, what's our payment model going to look like, and how is it going to address the opposite issue that we have right now? There's a couple of different ways to look at that. One, Medicaid pays based on medical necessity. They're going to need to redo as we add new services, they're going to look at the methodology. I can't tell you what that methodology is going to be. We're going to look at, you know, places in other states, what we currently do, what's best practice. And again, trying to make sure we get the right incentives built into it.
Yeah.
So I can come back to you once we've done the methodology review. I think the second piece, and this gave me a pause, is that we haven't seen the length of stay change that much from before when we had a fee for service model and now, and I think you heard that last week. And so I'm a little less concerned about like that overutilization at this point.
Okay, I'd love to be up to date on this. It's something I'm very passionate about, as you know. So
Absolutely.
yeah, and then also the decision of that, the methodology of moving people out of facilities. Also, I think that some consideration should be made of to ensure that that decision is being made above the level of people like me, because then the clients get eager at us because we're
I hear you.
kicking them out. So yeah, it leads to a lot of friction.
I hear you. And
We'll
we
get to
we are challenged with that in other parts of our system. And I think there's a lot that we can learn from like the mental health sector. I want to be cognizant of time. I know.
I know, Senator Cummings has a question, and then we do want to allow you to finish.
This bill helpful, harmful?
Oh, no, we're changing the bill.
We're changing the
I
bill.
would recommend that we are happy to work with the providers, and we're happy to work with some of the other constituents like the families and help bring, like, we've already been in conversations. What makes sense? The problem you're trying to solve is ensuring people get a chance to get the care they need when they need it for as long as they need it. We think that there's a way to do that. And so we will work with folks around changing.
No matter what.
And some of these elements are not policy elements, they're budget elements. And so, but I want to make sure that you all are informed about what we're doing from that. So I'm gonna buzz through the rest without a lot of
Policy, budget is
policy. Budget is
It
policy.
represents your values, right?
It's where you invest your money. It's
Yeah,
why
it is.
my team will tell you I force budget and policy to work together even when they don't want to.
Good.
So, let's, right, you said we're doing a full continuum. When we think about the continuum, as you mentioned, Senator, recovery housing is an important component of that. We know that we need, 200 to 250 recovery housing beds in the state. Housing units, that's like, this project suffers from that. We need units. We can't just bring them up. So this year, what we decided to focus on was really bringing together recovery housing, knowing that some of the folks that are coming out of our residential treatment centers also would benefit from having an integrated model where they can get recovery housing, intensive outpatient, and other life skill supports all in one place. You see that with like Agenda's Promise, where folks who are really at high intensity and really have not had the opportunity to develop some of those skills need more support rather than just either going home or going to traditional recovery housing where they have to navigate on their own, getting to outpatient and getting a job and all of this and many of the other things that are going to be successful. So we are proposing in the budget, expanding our recovery housing by 15 beds of more of a higher intensity recovery housing. We've done an RFI already because we want this to get on the ground, most of these proposals on the ground and going as close to, if the funding is appropriate, as close to the beginning of the fiscal year as possible. And an RFP will be forthcoming contingent on the availability of funds for this. It's important for us to recognize, as I said before, that we need to continue to think about treatment innovations. What we're doing for opioid use disorder is not fully worked. Some of it is, but not all of it is working for stimulants. So we are looking at putting in, continuing to advance contingency management, which are incentives that really help bring about intrinsic motivation to stay in recovery. And then also pretrial supervision. We know that what we're seeing are significant recidivism. Why wait until someone is desperate enough to shoplift again or do other or have other crimes when they're already involved in the judicial system? And so pairing them up similar to what we see in probation and parole with someone who is monitoring their compliance with what the order is when they leave the judicial system in terms of being released, and catching it when someone's not like is struggling with their treatment before they get to the point of recidivism. And so we want to make sure, as I said before, I don't want more people in corrections. I want more people in residential treatment outside. And so this helps make that both accountability and support available to them. So buzzing through, I know we're just about out of time. There are a couple of Medicaid specific initiatives. I'm going to give my voice a little bit of a pause and hand it over to Monica to kind of walk through the Medicaid initiatives. And then we're also going to walk through, okay, so where are you going to see this? Most of it's in the budget. We'll go through where you're going to see that in the budget and how much.
For the record, Monica Ogilvy, State Medicaid Director, part of the executive leadership team of the agency. Thank you for having me. So thinking about the continuum that the Secretary has just put forward, the treatment, the support doesn't end there once you've left treatment. Many people are going to remain in treatment forever. So how do we support these individuals to live in the community and thrive? So there's a handful of Medicaid initiatives where we see a lot of intersect here. The first one is our permanent supportive housing program. This we had authority to implement effective this past January 1st. This is something that we're going to hope to pair with some rental assistance that we just recently got authority through our 1115 waiver from CMS under the previous administration. The permanent supportive housing program is evidence-based intervention that has been demonstrated to be effective in reducing homelessness. We are going to have authority to do this through our 1115 waiver, and it's going to help us support people with complex health and social needs to successfully transition into maintaining residency in permanent housing. So when people say, like, what does that actually look like? Imagine some of these individuals have been living incredibly challenging lives, have never learned some of those life skills in how to be a tenant, how to fill out an application, how to get the appropriate identification to live in a place, how to pay your rent on time, really basic life skills. So this is actually providing individuals with the support to set up utilities, get the things that they need in order to live in their space, be a good tenant, communicate with a landlord, be a neighbor. And that's going to be in partnership with our housing partners throughout the state that already do this really beautifully. Additionally, with the new authority for rental assistance, we are really hopeful that for a narrow population within the permanent supportive housing program, that we'll be able to provide some of that rental assistance to help people get their feet on the ground, get established with a safe place to live, because we know that that's fundamentally important to somebody's success out in the community. Additionally, your question really made me think about this. we've also gotten authority through CMS to the Central for Medicaid and Medicare to establish a reentry services program. So this is for individuals that are going to be leaving corrections that will have access to Medicaid services, primarily some intensive care coordination, up to 90 days in advance of leaving incarceration. And we recognize that that date can move and can be squishy. So we will also move and be squishy with it. We're not going to wait too long. We want to get in there ahead of time to make sure that people have appropriate forms of identification, that they're connected to treatment outside, that they have a primary care provider, a dentist, a place to live, all the things that are really important to make people successful out in the community. But what triggered my thought when you were asking that is when people say like, oh, I don't want to leave yet. Sometimes I think it's really important for us to recognize that maybe there are basic things we've not done for them. And this is no commentary on anyone yet, but our system clearly is not filling all of the gaps of those fundamental needs. And this to me feels like a really critical place for us to be doing that.
And this is synonymous to the navigation services out of residential treatment. We're going to provide residential treatment inside of incarceration, then we need to provide the navigation. This goes broader than for those in substance use treatment, but it's really important.
But as you're talking, obviously the care and the continuum of care needs to exist regardless of where the patient lives.
Correct.
The patient can live and be incarcerated, or the patient can live in the community, but we need to have that consistency in place. So yeah, and
our recovery partners, I know you heard a bit of this yesterday, our recovery partners have shared over and over again that it's scary to be out in the community and attempting to live independently and do this well and do it quote unquote right. And so our objective here is to wrap them around every step of the way with the services and support so that they can do that successfully. Because I wouldn't want to leave what felt safe either.
No. So I'm going to pause there, Chair, because the rest of the slides really go into where it is in the budget. We put them in there just so you had context to see how much and what it is, but each one of them flows from what our conversation is today. So I'm going to turn it back over to you because I know you have some time pressures.
we do. And but this is really an important conversation for us. I mean, S36 has triggered a lot for us, and we worked last year on S186. So now it's time to take steps forward. And I'm really appreciative of the work that you're doing. We'll look to you for some guidance, and Chad for some guidance on getting language into S36 that may well enhance the budgetary requests. I don't know what's in the public safety bill. And the suggestion about having some joint meeting with judiciary that may come up as well. And then the other thing that we're going to have to think about in here, and I don't know whether you've been thinking about it or not, is that we have folks who have substance use disorder, but also have mental health needs and the co-occurring disorders that we see, and how that is coordinated and integrated, I don't know, within the agency somehow to build a system of administration within the agency. So we may want to be thinking about that as well. But that's us, and you, I guess. Yeah.
That's helpful. And so I appreciate the opportunity to be here. We did bring our departments so that you.
I see that. And corrections is here. I think this might be the first time that the commissioner has been here. Have you been?
I think this is my first.
Yeah, I know.
I wanted to introduce, I did want to introduce our.
Please do, please do.
So this proposal really reflects the.
Senator work. So here.
This proposal reflects a lot of cross-agency work.
Senator Hart. Can you please, you can sit down.
Yeah, I can swing by.
This proposal reflects cross-agency work. It's the value of having an agency all together. And for me, we're unique in Vermont to have corrections. And so I'd like to at least introduce Commissioner Demmel, Nick Demmel, who is with corrections, and his team, who is really foundational, along with Emily Truder, who is from the Department of Health, and Nicole D'Estasio from the Department for Mental Health. If you have any questions about the elements of the proposal, we're happy to take them as a team, but I also want you to put names and faces together. And again, it reflects a level of collaboration, having been in the agency for 19 years, that I think really is what we've been striving for years, but have not achieved. And so this proposal is, I just want to give the team credit for that.
We're all about it in this room.
Yeah.
And knowing that the MAT discussion actually, I think, started in this room with the former secretary and the chair of judiciary and the commissioner of DOC and others. And how can we help treat patients in corrections the same way we treat patients outside? So it's an ongoing process. It isn't simple, and it does, the problem is, it's a problem and a solution. It does require coordination. So thank you for that.
Final question.
Yes.
So just for my own edification, Karen, will you be providing recommendations to incorporate corrections into S 33, 36?
The chair is requested that it would be helpful, and so and it also would be helpful for that to be coordinated with some of the other community partners who we work with closely.
Yes.
So we're going to take that on to do that and work with the community.
Thank you.
Thank you.
Thank you very much. Thank you all for being here and taking time out of your day and getting here on the icy roads. I know I had to.
Always not.
Yeah.
So maybe I should do something that about
Yeah.
I'm on the board.
You're a warrior.
Hold on to that. We got one more thing to do.
Thanks, everybody.
Oh,
I don't know what I had to do.
Oh.
Yeah.